And you guys just probably don't know exactly how this is done in these altered anatomy. So I thought we'll just talk about these doing the ERCP in this altered anatomy patients. So can we move? So I do some consultation to Medtronic, so I'm not going to discuss anything in this in today's lecture that is related to that. I will talk about some industry-related products, but that I have no financial relationship to. Okay. So what is the big deal? How is this different than any ERCP that all of you have seen and done, many probably? So most of the time, as you all can see in this picture to the right, you can't make nothing out of it. What is going into what, and where is this? And depending on the mood of the surgeon who did this, which limb got attached to which limb, and we don't, it's just very, so very, very complex and very, not really easy to make a route out of all of this. So which limb it is? It's always a question. When we do these cases, where do we go? There's usually sometimes 4 holes. Which one? Which one takes me to the liver? Which one takes me to the pancreas? So it is really very confusing sometimes to know that. And then can we get there? A lot of these are very long limbs that was, again, created for a certain reason. So is that scope that's about 1.5 yards, can it get me actually there when I know the road is about 3-4 yards? How can I get there? Can I get there, and do this procedure? And then with all the ERCPs that we do, we teach our fellows, and we always talk with our nurses that, you keep this position, you keep it at 11 o'clock, you're underneath the papilla, then you're successful. On this, and we'll see some pictures, it is just the other way around. The orientation, the cannulation is all the way from the other side. So it is not the standard stuff that you usually see. And then not only that, but we're just trying to also improvise here perform interventions with devices that are not actually made for this. We're trying to see maybe this will work, maybe this will work. So that we happen to be just a very high volume center and we do all these things. We've developed just some tools and that we have in certain in a box that we call them basically the altered anatomy ERCP, but it's just not something that truly was made for this. And then a lot of time with these long routes that you have to travel to get to the liver or to the pancreas, oftentimes the scope is not stable. And you have like 2 nurses holding the scope, you have 2 nurses trying to push the wires, so it is really not an easy thing. So that's why we're going to talk about it today. And what I'm going to try to do, I don't think anybody can become an expert in this in just a lecture or a day or 2 or truly a month, but just to give you guys a glimpse of, what we do, how we do it, maybe some tips if anybody is interested in doing this and if anybody is interested in developing a program for this. Can we move, please? So before that, something that I really like and I'm passionate about is the relationship between MDs and RNs, especially in endoscopy. So, and I'll talk about this in this pre-procedure planning. I think for a successful outcome for any procedure, the physician, the nurse have to come together and talk about these things. Even just the standard procedure, if we're doing a procedure for dilation, I think if we're going to do the best for this patient is we're going to have to talk before this and say, okay, and I always do, I hope some of my nurses would attest to that, is okay, even a simple esophageal structure dilation that I would come with the nurse, okay, Linda, we have this patient with a stricture at 35 centimeter. I think it's better than before. The plan is to go with a standard EGD scope or maybe a cap, and then plan to do either severe dilation or balloon dilation. If I do balloon dilation, most likely I will use a 10 to 12 and probably take it 12 to 15. I may use a wire. I need this patient on fluoroscopy. We have a full plan. So everybody's prepared. The nurse is prepared, not only just like prepared physically and she has the stuff, but even mentally that she's actually prepared for this. So that saves so much time. And she sometimes, a lot of times, she actually will come up to me and just say, well, we need this, or maybe if we use this, we're better use fluoro and things like that. So this is really, it's just not a one-way thing. It's just not like just some orders, that I give the nurses, but it's actually just a two-way thing, and I think it really works well. So before any procedure, especially these altered anatomy ERCP, very complex procedure, so we need to get together and talk about a few things. The first thing is the operative reports, okay? So we have a patient, we know usually this patient was transferred, or our own patient that actually has this altered anatomy. We need to sit together and say, what happened to this patient? Who did what to this patient? Okay, and so we know what we need to do and how can we do it. So a lot of time we have to look into the operative reports. Usually this is the physician would do that. And then look into the length of this surgically created pancreaticobiliary limb. A lot of time this can be short, so you can use a scope that's actually appropriate for that. This can be extremely long, and then you would use a different scope or a different tool. The other thing is the type of anastomosis. A lot of time you would actually travel a long route and then find a native papilla. So that would you would use certain tools. Sometimes there will be just what we call just an anastomosis. The bile duct is basically attached to the bowel, and you don't need, you can use a different tools for that. So we need to talk about that. We need to plan this. And then after this, pick the appropriate endoscope and the approach. So different surgeries, you will probably use different scopes, like I said, different tools, and we'll talk specifically about all of this stuff. We move. Next, please. So I think even for standard ERCPs, I think the expertise of the team, the physicians and the nurses who are doing this is paramount and very, very important. But having said that about the standard ERCPs, this is, I think it's a major step ahead of the game here that really needs the team to be up to speed. So you need expertise in the standard basic ERCPs from both the physicians and the nurses. And if you're using a special scope like a balloon-assisted enteroscopy, I think both the physician and the nurses have to have expertise in performing these kind of procedures. I mean, this may sound just easy, but whoever set up a double balloon enteroscope, I know a lot of our nurses have done, know how difficult of a task it is. And these little things that can make things successful that you may just get stuck. So you really have to be ready to be able to do these kind of procedures. And these are long procedures, so you really have to have anesthesia with you. Don't even think about doing these with sedation. These are an hour and a half, 2 hours, sometimes even more. So you do need your anesthesia colleagues here. Next, please. So having said that, not every patient who had surgery on their gut is actually going to need any special, situation. Actually, we could just use our standard duodenoscope and the tome and the wires that we use for the standard ERCPs. So I just want to go through a few of these things that actually it's okay. So can we next, please? Next again. So you'll see patients after resection for esophageal cancer, and they have esophagectomy, basically removal of the lower part of the esophagus with gastric pull-up. And those patients, as you guys can see, the right, this is normal to the left. The right actually is that post-surgical anatomy, but it doesn't really change the location of the duodenum. So you can just go ahead and just treat this as you would any other patient. Next, please. One more. Sleeve gastrectomy is another bariatric surgery, and it would not really change your duodenum approach or duodenum location. A little, different anatomy, but it actually, you'll still use the same tools and everything. So next, please, twice. One more. So vertical banded gastroplasty and laparoscopic adjustable gastric band, the same thing. The anatomy is different, but the scope would actually pass through the esophagus and go down through the stomach into the duodenum. So standard ERCP, no reason to worry or change any of your planning. Next, please. And one more. Bilirubin 1, it's a kind of an old surgery, but we still see some patients. Usually it's done for ulcer disease, where they remove part of the stomach, and that's how it becomes. Again, the duodenum is not changed, so we really, the approach to the duodenum is still the same. So all these surgeries you don't need to do anything different. Next, please. And colodocoduodenostomy, you'll see that sometimes or hear about it after liver transplant. And again, you would use the same duodenoscope, the same wires, the same everything. No, no worries. It took me years. I've been doing GI since 2008, but now I can at least try to recognize when somebody tells me this. But I can tell you, it took me probably 4 or 5 years to be able to grasp all this. I used many years. If I hear about something like this, is just Google it, just see what kind of anatomy and understand like your route. You need to go through the esophagus, into the stomach, and to the duodenum. So don't feel like you really have to remember all these things. If you hear about something that you don't know, just Google it, see what kind of picture you're getting, and just trying to understand which route you're going to have to take to go down to the duodenum. Next. So getting to the more fun is all these post-surgical anatomy that would actually need something special. And we'll start with Billroth 2 gastrectomy and then move to Whipple procedure. We see a lot of patients. I'm sure you guys see a lot of patients with these. Roux-en-Y hepaticojejunostomy, and then we'll end up with the gastric bypass Roux-en-Y. Okay, next please. So this is nobody has a pointer, guys? How am I going to pick on you guys? Okay. Oh, we have a pointer. Oh, goodness. You saved my day. All right. Green? Okay. You guys heard green. Okay, because you guys will have to do it. Okay, so this is Billroth 2 gastrectomy. This is Billroth 2 gastrectomy. As you guys can see, everybody, I'm hoping. So the distal part of the stomach, this is the esophagus. So this is esophagus, stomach. The distal part of the stomach is actually taken out, and there's a loop of jejunum that goes all the way around and basically goes into the pancreas and the bile duct right here. Again, on that side, esophagus here, stomach, and then a loop of jejunum here. This is called, because it's a jejunum attached to the stomach, gastrojejunostomy. So stomach gastrojejunostomy, anastomosis. And there is this afferent limb and efferent limb. Okay, don't worry about these names. It's very confusing. But basically, this limb would actually take you to the pancreas and to the bile duct. So who's going to start? If I'm going to do an ERCP to this guy, can anybody tell me where's my scope have to be? Do I throw this and somebody take it? Where are we going to start? Heather, you want to try that?
The efferent limb?
Yeah, okay, take it from the esophagus. Oh, okay. Can we go next, please? Okay. Go, Heather. Okay. Next. Keep going. Okay. Follow Heather. Okay, Tim, keep going. There you go. Cool. Keep going. Next. Next. Okay, keep going. And then we can see this, right? Fantastic. Thank you, Heather. That was nice job. So truly, I mean, it's not really hard. I'm sorry if I'm picking on you. Everybody else will get there. So that I'm hoping, I don't know if we need to dim the lights. Can you guys see okay? Good. So this is, again, you can just pull up this image, and just like what Heather did, just basically look and see, where do I need to get to the papilla? I need to get a stone. I need to open up a stricture or something. And all I need to do is just go through the anatomy and just be able to get to that. Okay, you can find this image in less than 30 seconds on any, on just a Google search, okay? So once Heather got us there, and then we got this. Linda, you've done a lot of ERCPs. What is wrong with this picture? Or anybody who's done ERCP. Linda, what do you think? You can't see? Yeah. Can we dim the lights a little bit? Is that possible, Tim? Maybe. Try it. No? Okay. Yeah, that wasn't going to help much, I think. Are you the technical support, sir? Can we dim the lights? Oh, is it better?
So it's probably on the bottom of that one.
Oh, I think he's coming there. No. Oh, wow, that's like a party now. All right, Linda, no excuse now. Anybody can take a, if you guys can see. How many of you guys do ERCPs or done ERCPs? Okay, good. Excellent. Huh? Upside down, huh? It's right? Usually, for people who's done this, usually should be here, right? It's on the right. And this is, we call this the intraduodenal portion. It's actually on the other side, looking up, right? We're usually underneath this, and we're actually looking at the papilla above us, and that part here is actually on the other side. So this is just flipped upside down. So when I was talking to you guys about actually the orientation, the whole thing is just flipped upside down. So there is definitely a problem with this image. And then can we go next, please? So one thing we need to know about these patients, and I think that good tips about these Billroth 2 patients, is the gastrojejunal anastomosis to the major papilla is not very far. It's about 30 centimeters to 50 centimeters. So it's really reachable. It's not very far to go from here. From the stomach all the way to the papilla, it's not very far. Okay, so you won't need a very long scope to do that. Can I? Does this move? No, that doesn't move. Next, please. So because of that, because it's not very long, you can actually just use a gastroscope sometimes. A gastroscope would get you through this and get you to the papilla. You can use a duodenoscope, just a regular duodenoscope, and you can. With that, you can use standard ERCP devices. Sometimes, if it's really there's a lot of adhesions, a lot of scarring, you may need to use a pediatric colonoscope, or sometimes an enteroscope may be required to go all the way through to the papilla. Next, please. So next, one more, and one more. So when you get to the gastrojejunal anastomosis, a lot of the times we'll just park there and you'll see 2 routes. When you get to the fork, what do? Like which limb do you take? And if you take this limb, the efferent limb, you're going down to the intestine and the pelvis, and you're spending 20 minutes, 25 minutes. The nurse is like, "What are you doing?" So because you can't get to nowhere, you need to get to the liver, and you can't get anywhere. So what you need to do is to look for any signs that says biliary limb, and you won't find any, unfortunately. So what do you do next, please? Next. So maybe you look for the amount of bile. You would hope that in that biliary limb, because it's coming from the liver, that you will see more bile. And then you look for peristalsis. In that efferent limb, usually the peristalsis are going away from you. So that can help you to try to avoid going into the wrong limb. And fluoroscopy may help. Sometimes you just pick that limb and then put the scope in it. And you should see on X-ray your scope. Go back, please. You should see your scope going to toward the liver on fluoroscopy, so you're in the right limb. A lot of time it's actually few, and a lot of time actually I would ask my nurses, like, which one do you think? So this is very important. I think it's usually the one that has actually an acute angle. If you see something simple, it's not going to be that. So that's just life, right? But it's not going to be. I assure you, if you see something straightforward, that is usually that efferent limb that's just going straight forward. It's usually a more angulated, up to the left, hard to see, and that's where you need to go, and that's what's going to get you there. Okay, next, please. Next. So again, Linda got it really well. If you guys can see this is the normal anatomy. This is your papilla, and this is where you're going. The biliary orifice is at 11 o'clock or 12 o'clock, okay? So you're underneath the papilla. This is how we do ERCPs normally. Next, please. And this guy is just flipped upside down. Okay, so instead of 11 o'clock, we're talking about at 5 o'clock is where you need to go. And the same thing here, guys, it's just going the other way. Okay, next. So there is a problem of orientation. And we're talking about the papilla here, okay? Next, please. So what do we do about that? It's actually we have to use something that we can rotate. If it's 11 o'clock, those devices are actually designed for that 11 o'clock position. So we can use a rotatable sphincterotome. Boston makes this sphincterotome that you can actually rotate. So with that, sometimes we kind of just empirically try, usually we go counterclockwise, we try 4 times and see if that orientation is the right orientation. So it's really trying to improvise and trying to make the best out of what you have. Most of the time, it does work, though. Next, please. Next. One more. So if you can't get that sphincter tone to, again, it's not designed to do that. It does that most of the time. If you can't do that, you can use a swing tip cannula that actually goes both ways, so it can help you to get your orientation right. Or you can just use a straight cannula, regular ERCP cannula, that you can actually just, you and your nurses try to mess around with and say, well, this is like the orientation that I want to be, and put it in some warm water and make it a little bit more flexible. So a lot of trials to get the orientation right to get through this. Next, please. And one more. And sometimes because of this kind of a weird orientation, also using a distal attachment cap can actually help us a lot, actually, because you can see where the papilla is, and it can help you basically just get into the right orientation. So I'm trying to say all these things, guys. Again, I don't think anybody should really try to, I need to learn all these things and tips. I can give you guys my presentation, but these are tips that just with our experience, with the years of me and others that have done this, just things that can actually help and can make your life easier if you're trying to do something like this. And that's what I would like to share with you guys. Next, please. Next. So what if you can't get that orientation right to do a sphincterotomy? As you guys may have heard and seen, a lot of the people who do ERCPs, is bleeding can happen if you don't get if you don't do sphincterotomy in the right spot. Perforation can happen if you don't do sphincterotomy in the right spot. Again, we're talking about, instead of going 11 o'clock, we're going at 5 o'clock. So really difficult spot to do. So next, please. So if we're having difficulty getting our tools to go in the right orientation, what we do sometimes is just put a small biliary stent and do a needle knife sphincterotomy over that. That is a lot safer than just trying to do a sphincterotomy blindly. Next, please. And then if not, I know most of the nurses who've done ERCPs know that we try not to do balloon sphincteroplasty. That means if you get into the bile duct, instead of opening the bile duct and just put a balloon and actually inflate that balloon, we try to avoid that because that can actually crush the pancreas and cause pretty bad pancreatitis. However, in this situation, it's probably safer to do. If you're not comfortable with doing a sphincterotomy in this orientation, you're probably much, much better off with just putting a balloon and inflating and basically rupturing that sphincter. We call that, the more nice term for that is balloon sphincteroplasty. And it's actually been shown that in this setting, it's actually probably much safer and a lot lower risk of bleeding. So that can be done as well. Next, please. So in Billroth 2, when we saw that, because it's very close to the stomach, actually there are excellent results for ERCP in Billroth 2. It's almost, if we have any patients with Billroth 2, we can almost guarantee we're going to be successful with that. Next, please. So up to, almost 100% success rate, really getting to that papilla, and then to get in the bile duct and do the treatment that you need, up to 90%. So that's really excellent results. Next, please. So if you want to use a forward viewing scope, usually with a cap, that's again up to 90%. So really in Billroth 2 in specific, we have excellent results doing ERCPs despite the altered anatomy. Next, please. I personally like to use actually also a forward viewing scope, gastroscope, or a pediatric colonoscope to do these Billroth 2 rather than actually a duodenoscope because there have been less reports of less perforations with using a forward viewing scopes. And that I mean just a regular EGD scope or a therapeutic EGD scope rather than using a duodenoscope. Excuse me. Okay, any questions so far, guys? Next, please. Okay, so here's the picture again. Everybody can take us there, you think? Good. Okay. I mean, it's really not a rocket science as long as you're trying to imagine which route. Go ahead. Keep going, please. Next. Yep. Very nice. Keep going. All right. Keep going. Very nice. If the computer knows where to go, guys, hopefully we will know, right? So, again, this is the go next again. Okay. So what is this, guys? The biliary, right? The papilla and the biliary orifice. Can somebody? I know some of the nurses will know, but where is the pancreas usually on a routine, just ERCP? Which orientation would that be? If 11 or 12, is the bile duct. Where's the pancreas usually? 3 o'clock, right? Yeah, to the right, 3 o'clock. What do you guys think on a Billroth 2 then? Where would it be?
9 o'clock.
Yeah, go ahead. Next, please. That's biliary. Next. Yep, go ahead, one more. Fantastic. So exactly, just the opposite, exactly the opposite. So you're trying to really just take a flip image of what you would do in the normal ERCP. Next, please. So taking it a little bit further to a Whipple resection. So this is when things start getting messy, not as messy as it can get, but so it's a little bit more complex anatomy where you can see the stomach here attached to a loop of jejunum here, and then there's a loop of jejunum that goes all the way to the liver, and there's no papilla there. There's a bile duct attached to the jejunum here. So we call that a colodocojejunostomy. Colodoco is anything that's, that has to do with bile duct, and jejunostomy because of the jejunum. And there's also attachment of the pancreas to the jejunum. This surgery, basically, if somebody has like a pancreatic head cancer, and we remove that duodenum and the pancreatic head. Okay, so here it is, guys. So stomach, loop of jejunum, and then we go down into this. That's the attachment of the bile duct to the jejunum, colodocojejunostomy, and then the attachment of the jejunum to the pancreas, PJ, or just the pancreatic jejunostomy is what you would call that. Next, please. Keep going. Can you guys take us also? I don't need to pick on anybody. Keep going. Very nice. Okay. A computer knows everything. So again, we're going to have a problem here knowing which route to go. The same thing. We're trying to look under fluoroscopy. We're trying to look at peristalsis, to look at the angles of where we're going, and then finally get there. Next, please. And then when we get there, we're not going to find a papilla. What we're going to find is actually attachment of the bile duct to the jejunum. Here is actually, I don't know if you guys can see that clearly, basically just a small opening of the bile duct into the jejunum. This is nice. It's patent, actually. The patient didn't have any problems with this. But it'll be nice if we see the opening as wide as this every time. I know our nurses would know that we would spend sometimes 15, 20 minutes looking for it because it's so tiny, because that's why the patient is here. Usually it's a stricture, you can't see it, but this is a patient that came to me actually because he had a problem with the other anastomosis, with the pancreatic anastomosis. So that was just, I thought it would be nice just to show you guys how this would look normally. Next, please. So the efferent limb, if you take it from the stomach all the way to the bile duct anastomosis, is about from here, the red, all the way here, a little bit longer. Now we're starting to get a little bit, more long here. So 40 to 60 centimeters. With Billroth 2, we said about 30 to 50, so really shorter. Now 40 to 60 centimeters to get to the anastomosis. And the difference between the colodoco-jejunal anastomosis and the pancreatic-jejunal anastomosis is about usually 10 centimeters. So it is important sometimes because, like in that patient that I just showed you guys, I was looking for the PJ, for the pancreatic anastomosis, and I couldn't see that. But knowing that actually, I could see the bile duct opening, I know that the pancreatic anastomosis would be actually upstream, right? It definitely would be upstream of that. And usually you'll take it about 2 to 3 inches, about 10 centimeter, where you should actually find that anastomosis. So a lot of, again, just some technical little small tips that you would actually try to use, but it usually gets you there and does help you. So to be able to do an ERCP in a patient with Whipple procedure, you would need duodenoscope, gastroscope, and that would get you there because it's not very far, or sometimes you would need a pediatric colonoscope. My favorite, again, for these is a pediatric colonoscope. It really can get you there pretty straightforward, and you have enough scope length to get there. Next, please. So the hepatico-jejunal and pancreatico-jejunal, most of the time when we do this procedure, there is suspicion of actually a stricture at the anastomosis. So, you won't see that this is just so nice. This is, I don't know if you guys can see, it's a pinpoint opening. Sometimes that's all you get to see, a little pinpoint, little hole. That's all that anastomosis that you can see. This is the same patient, this guy, the first one and the third one. This is the PJ, the pancreatico-jejunal anastomosis. You can see how stricture, this is the opening. That's it. So this patient usually comes in with dilation of the pancreatic duct. They have pain after Whipple surgery. They have recurrent episodes of pancreatitis. So you know that it's not going to be easy to find that opening. So what do? You you use fluoroscopy again. You think this is around the liver. This is where I would expect that bile duct to be actually coming into the jejunum. And a little bit further up from that, toward the midline, is where you would find the pancreas attaching to the jejunum. So you try to use all these kind of small tips to be able to find these. One thing that really helps if we use a pediatric colonoscope is to use a cap. You can see all these folds sometimes, and just trying to find this little pinhole opening using a cap can actually open these small folds, so you can actually see this opening. We were hoping we talked to our surgeons who do these cases if they can just put a tattoo for us, for God's sake. It's like sometimes we would really look for an hour, and the nurses with us was like, "Where do you think?" And I think it's there. I think it's there. It really can be very tricky to find there. So we have not been successful in convincing the surgeons to put a tattoo for us. So next, please. And keep going, please. Next. Yep. You guys can see where we're going? Okay, fantastic. Okay, well, let's get a little bit more messy even. So Whipple, everybody, any questions so far? We can take a little 10-second break, but trying to digest all this nonsense. Any questions, guys, so far? Oh, good. Excellent. So this is Roux-en-Y hepaticojejunostomy, okay? I'm sure most of you guys you'll probably hear about it if you get a patient to take care of, but most of this is a very specialized. You see it only in two settings generally, is the liver transplant patient, or a patient who had an injury after gallbladder, after cholecystectomy, and they needed a repair for that. So this is just about the 2 times that you would hear about this term called Roux-en-Y hepaticojejunostomy. So what happens here, we need to get to the bile duct attachment to the jejunum here. There's that jejunum here, and there's attachment here into the jejunum, and goes all the way back to the stomach, okay? So here it is, guys. Esophagus, stomach, we go all the way down to the jejunum. There's jejunum attached to the jejunum here, so we call that a jejunojejunostomy. Jejunum attached to the jejunum, jejunojejunostomy, or jejunal anastomosis. I was like, I don't think I'm talking English here. People's like, what are you talking about? And then we take it all the way up into the connection of the bile duct to the jejunum, so we call that a choledochojejunostomy, or sometimes because it's the hepatic ducts that are attached to the jejunum, you will call that a hepaticojejunostomy, okay? And that's basically it. Can we go next? Okay, keep going, please. Are you guys following? Fantastic, keep going. All right, and now stop here, please. And now we get into this again. We get into this road. We're like, okay, we're down in the bowels, and we don't know which route to take. The same thing again. Just don't take the easy route. Believe me, this is just not going to work. I've tried it many times. It just doesn't work. So try to, usually what you would look for, again, and the nurses there, usually, people who do this know that we ask them, which one do you think is the right one? And usually you would see bile coming from that, more bile into that limb. Usually it is a more angulated, angulated limb to go through. And usually it is to the left of the visual field. It's up and to the left of the visual field. Usually that does work. If it doesn't work, then you'll find yourself, and under fluoroscopy, you're in the pelvis. It's like, I don't think the liver is here, guys. Let's get back. And by that time, it's probably like 20, 25 minutes already. And, your anesthesiologist is sick of this, and you're sick of it. And so, these are just not something that anybody really would want to do on a daily basis. So next, please. So if you go through the efferent limb, and we keep going, please. And one more. Good. And one more. Okay, so that's basically what it takes. So a really long route to go with these Roux-en-Y hepaticojejunostomy. It is not as simple as Billroth 2 or Whipple procedure. Next, please. So, and when you get there, you don't anticipate to see a papilla. What you're going to see is that anastomosis that we talked about. This is it, guys. See that? This is actually an actual patient that we did. It is usually a very little. Sometimes you would use a cap to try to look in between these folds. You'll see where the bile is coming from. If you can't see any bile, sometimes we would just basically fill up the jejunum with water and hope that the liver is going to excrete some bile so we can see where it is. It's pretty pathetic sometimes. We're just sitting there and we don't know where it is, but you try to do all these little things and trying to look for it. And we'll talk about the success rate for that. That's not too bad. Next, please. So what you can use is either a pediatric colonoscope because of the length of that route, or you can use an enteroscope, usually a balloon-assisted enteroscope, one of those. Next, please. Oh, actually, go back. I'm sorry. Go back. Okay. Sometimes, depending on the anastomosis, there's actually either one anastomosis to the jejunum here. Sometimes, and that's why I said, you have to talk to the surgeon who did the procedure, review the operative report. Sometimes the jejunum is actually attached up here into both ducts. So I've seen it actually even 3 ducts. Some patients have an unusual anatomy, so they can have actually 3 anastomoses, 3 biliary enteric anastomosis. So you really have to know your anatomy. I know at least of one patient that actually had some treatment for this, and they opened up one anastomosis, and the patient didn't improve. Well, simply because that patient had 2 anastomoses, and the other one was actually the one that was stenosed, not the one that was worked on. So you really have to know what anatomy. I usually go in details into these operative reports before you go, so you know where are these anastomoses, how many anastomoses these patients have. And if you need to do an ERCP for pancreatic indications, then this has nothing to do with, like I said, this is Roux-en-Y hepaticojejunostomy. All this has to do is the liver, attachment with the jejunum. So the pancreas, you should just go there and go to the pancreas, and that would be okay without any problem. So if you need to do anything for pancreatitis or like a stone in the pancreas, you just use your standard ERCP scope for that. Okay, next please. So I thought, since we're talking about this, we use quite often in these patients with very long limbs, we use balloon-assisted enteroscopy. So there are 2 systems mainly that are available widely for this, is the single balloon scope and the double balloon scope. Most of the people have single balloon scopes. How many people have single balloons in their unit? Do you guys, anybody other than us? Okay. Have you guys seen single balloon? Oh, wow. Cool. Okay. So yeah, see, a lot of you probably haven't seen any of these cases then. Yeah, I mean, it's a very specialized thing. So not only single balloon, we have a double balloon as well. And then the double balloon comes in short and long scope as well. And all these devices are trying just to get us there, to try to get us through this long route. And these are just some specifications. Again, if you're going to do these procedures, you're going to actually need tools that are actually compatible with this. So a lot of our balloons are actually 170 centimeter. So you have a scope that's actually 200 centimeter, and you're trying to put a tool that's not even as long as, it's just not going to work, So you really, and that's what I put this here, is we really need to know our scopes and our tools. We have these actually hung up in each endoscopy unit at the university hospital, and I can't memorize these, or I'm sure some of the nurses are smart and can do that. But like we usually just go and check: can this actually balloon go through this scope? Is this big enough? Is the channel big enough? So these are important things to know. Next, please. This is the single balloon scope. It's just a thin scope with an over tube that has a balloon actually that inflates and deflates. What we're trying to do with this is go into the bowel, inflate that balloon, and basically pleat the bowel back, and then advance the scope and the over tube further, and basically pleat more bowel. If we don't have that long of a scope, I always tell my patients, then we're going to just bring the bowel back. The way we do this is just go basically inside the bowel, inflate that balloon, pleat some of the bowel back, and then go purchase more bowel. Okay, so that's basically the idea about this. The next one is the double balloon, just to get even more fun. So the scope itself has a balloon, and there's an overtube that has a balloon, and it just helps you to be able to pleat bowel in a more controlled fashion. Next, please. Can we play this video? This is just a simple demonstration of a double balloon scope. Can we play the video? So the scope is inserted into the stomach. And like I told you guys, we advance the scope. And then inflate that balloon on the scope. And then the overtube would go toward that balloon. And then you inflate the other balloon. And then deflate the first balloon. And then go further. And then inflate that balloon, deflate the other balloon, and get further. And I told you guys, we really need some experience with these. It's not rocket science, but you really need somebody who know what they're doing with these. And basically, you just keep doing that further and further, and basically pleat that bowel. That's how you can get through these long loops of bowel, so you can get to the liver anastomosis and the pancreas anastomosis and all these. Okay, next, please. Next. So overall success, remember guys, we were talking about the 100% and 90%. We're starting to drift down. You know, these are very long, very complex anatomy. So we're drifting down 75% success. Still very good, you know, if you compare it to actually somebody who's going to need like a percutaneous, PTC or surgery. I would take this chance, you know, of 75% success. So it's still pretty good odds here. Next, please. And, you know, truly, you know, we have all these interoscope methods at the university, and we try to use certain, scopes for certain patients. But truly, the research and the studies have shown no difference. You can use a single balloon, a double balloon. The double balloon is probably more successful, and we'll show you some data about that. But single balloon would do the job, I think. Next, please. Yeah, so the overall success rate is probably better with double balloon. At the university, up until about 6-7 months ago, we were just using single balloon scope, but we just got the double balloon scope. I think our nurses, though, have it on sale for half price if you guys want it. Nobody wants to do that, so. Next, please. So, and again, the duration is like 120 minutes, right? 2 hours, right? And then the nurses, you know, and us have that lead on for like 2 hours. Just imagine how much fun. Luckily, we don't get to do this more than once a day. It's terrible to just do it. Usually, you know, most of the places, most of the hospital, you know, this is a 1 monthly deal or something, you know. But we just get a lot of these patients and probably just do at least once or twice a day among the 3 or 4 endoscopists who are working. Next, please. Keep going, please. All right, you guys can take us. I'm hoping. Keep going. Keep going. Pretty long route, right, guys, huh? Keep going. Fantastic. Next. Okay. Even more, I think, a step further is the Roux-en-Y gastric bypass, okay? And as you guys know, this is one of the most commonly performed weight loss surgeries. Choledocholytitis is pretty common. Up to 50% of patients can have stones in their gallbladder. Good thing is most of the time, most surgeons actually do take the gallbladder out at that same time of the gastric bypass, but we end up with stones that are retained in the bile duct or issues in the bile duct after that, and it's really a rough route to go. Next, please. So even more fun. So this is the esophagus, gastric pouch, the small gastric pouch that they have, and you go into what's called the roux limb. And you go down all the way until you find an attachment of this jejunum to a jejunum. So again, we call that the jejunal anastomosis. And then you have to go back into where the papilla is. So really long route. Again, from here, go next, please. Next. Okay, next. So this roux limb is used to be, is a better statement, 10 to 150 centimeters. So a long route. You know, remember we were talking about 30, 50 centimeter. We took it to a 40, 60 centimeter. Now we're talking about 150 centimeters. So it's really getting there. More recent even, most of the bariatric surgeons are making this as long as they can, 200 centimeters even, to try to make, you know, the patient lose more weight. So it's a long route to go to reach this jejunal anastomosis. Next, please. And again, you're just going to get into the same thing, that fork in the road, you know, that you don't know where to go, and just use those tips that we talked about. Next, please. And then hopefully you're in the right limb. And keep going, please. Next. And then what you get here is to find a papilla, right? You find actually a normal papilla because this is the bile duct is going into the bowel. It's not like an anastomosis where the bile duct is inserted surgically into the bowel. Next, please. And again, that's how it is. We talked about this, and this is not trick or anything. This is just the reverse orientation. This is not the usual. This is not the routine way that we actually are used to look at papillas. The papilla should not be here. Papilla should be here, and we should be going this route or that route to get into the bile duct. Okay, next, please. So this is very challenging. I know most of us, when we have a case on the schedule of a Roux-en-Y bypass patient needing an ERCP, we don't feel good that day, just because it's just a very, very challenging procedure. So reaching the papilla may be difficult, and it's not guaranteed. So just imagine you do all these, resources and get all the team with you, and then and you may not able to get there. So you have to be ready for that kind of a frustration after trying for 2 hours. And then cannulating the major papilla from a kind of a very different position as well, not the usual position. And there's no elevator on these scopes that we use for the normal ERCPs. And giving that very long route again, very limited accessory devices to do this. Next, please. Can we play the video? So this is one of the. This is a case that I would show you. Again, guys, if you've seen ERCP before, and I've shown you guys how the orientation should be, this is very terrible orientation. You're going at the inferior orientation. The papilla is underneath you, instead of above you, and you're trying to work with these kind of tools actually to try to get in. So this is the papilla. This is a sphinctratome, and you're trying to find the bile duct. Usually we try to keep it at the 8 or 9 o'clock. Again, we're talking about so many clocks here, and every patient has these certain things. Yes, please.
I was going to ask, does positioning the patient supine versus semi-prone?
We'll talk. Excellent point. I think most of people would actually do the usual prone position for these kind of procedures. I personally like to keep them actually supine on their back, for this procedure, because a lot of time trying to go through this long route, you may need a lot of pressure, external pressure. So that really can help you, and the nurses can feel the scopes and can help you with that. So I know that a lot of people also are becoming more interested in different position. So this is a small stent. Again, like usually a lot of people, you'll put a 10 French stent, right? But in these kind of scopes, you can't put anything more than 7 French stents. So you really have to know, otherwise that 10 French stent is going to get stuck in the scope. And all that hard work that you get there, you're going to have to pull out all the way and then have to go back after cleaning that scope from the stent. So, cool. Any questions, guys, so far? Almost there. I'm sorry, this took a little longer. Next, please. So again, both single balloon, double balloon, and back, I don't know that anybody has it actually in practice these days. Spiral enteroscopy was, came into the market a few years ago, 5 or 6 years ago. Not many people have it, but all been shown to be effective with similar success rate in reaching the papilla. Next, please. So tips to increase success in Roux-en-Y. Roux-en-Y, truly ERCP is very, very difficult. So so to keep the papilla at 8 or 9 o'clock position during cannulation, so that is really, really very important. Again, if you don't know it, if you don't have experience, you won't know that, because usually you try to put it at 11 o'clock, but that is not going to help you. Distal attachment cap can be very, very helpful. Again, supine or left lateral position for easier application of external pressure. Most people advocate using CO2 because you're going through many loops of bowels. You don't want to distend those bowels and make them longer for you. What we actually use also is water. And these scopes don't have actually a special water jet in them, but our creative nurses usually hook up basically a syringe, actually just the water jet to the scope through the channel, and then you can actually use the pedal for that. And then instead of just insufflating air or CO2, we use actually water. So that can really help us get there easier and in a less distended bowel. And then fluoroscopy may be helpful. Sometimes we really get into the wrong limb and we just see that we're going more, into the pelvis. So we have to go back and figure out which one we went into and then take the other one. Next, please. So to try to overcome these problems with Roux-en-Y gastric bypass patients, there is another way to do this, and that's called laparoscopic-assisted transgastric ERCP. In that, what happens basically is a surgeon insert a 15-millimeter trocar. This is the trocar inserted into the excluded stomach. You know, if you put a scope in somebody's, through somebody's mouth, it's going to come down this route, right? And then you have to travel all the way back. But in this situation, a surgeon is actually laparoscopically, they open up the abdomen, they see where the excluded stomach is, and basically put a trocar here, and then they call you. It's like, okay, you're good to go, basically. So you have an actually access here, and then it's very easy because you're used to that, right? We're just put it into the stomach, and then just go down a little bit, a few inches, and here you are into the papilla. So that's a lot easier, technically a lot easier. You guys can see that just here, and the scope goes through the trocar into the duodenum here. Next, please. So that's how it looks like. It's nice. Back in the days, we used to actually have to get sterile for these because of the laparoscopy and the opening. But most of the time these days, they basically do the laparoscopy, they put in the trocar, and then they redrape the patient. So you don't have, or the team don't have to be sterile, and we can just go and basically do the ERCP through that trocar right here. Cool. Next, please. The downside to this, most of the patients, once we're done with the ERCP, is they're going to end up with a G tube, with a gastrostomy tube. I mean, remember, this is a patient who just came because of abnormal LFTs. It's not your 80-year-old patient who needs nutrition or something, and that patient is going to go home with a feeding tube in their stomach. So, and that's, just in case something happens, post-sphincterotomy bleeding, or there's a stone that you need to go back and get. So that's kind of a downside to that. The success rate is excellent. It's a very straight shot. You just get to the papilla quickly and then can do your ERCP. So the success rate is just about 100%. Next, please. So if we compare laparoscopic assisted ERCP, and we're talking about Roux-en-Y gastric bypass patient, to enteroscopy assisted ERCP, the winner is lap assisted, no question about it, 100%, right? So if we talk about the overall success, 100% versus 60%. So why? There you go. Yeah, what on earth, right? Okay, next, please. All right, that's why we don't do it. Because you can actually, it's actually, I was more like advocate of that, but you come to a patient and you tell them that, oh, this is going to be beautiful, and you guys going to all know it's going to be a little, a scar here, and we're just going to go in, take these stones out, or, do dilation or leave a stent or something, and we're just going to leave this gastrostomy tube for a month and take it out, right? Next thing, this patient wakes up with a big laparotomy because the surgeon could not find that stomach, or when he's trying to dissect to get into that excluded stomach, a little bleeding happened, and the patient is waking up with a laparotomy. So there's about 5% chance of turning into a laparotomy. Would I want to take this chance? Or that patient who just came in with a little stone and bile, want to take that chance? It's really a discussion to have with a patient, So, and something, a really major consideration for that. So the invasiveness of this, it is an invasive procedure. And then, patient is going to wake up with pain from the laparoscopy, still significant pain, and the mobility is limited. The risk of PE is higher, just with that being a surgery. So there's a lot of these, like the invasive components of just surgery is into that lap-assisted ERCP. And then, again, they're going to end up with a gastrostomy tube for a month or a month and a half again. And for somebody who's going to go back to work, if you just do an ERCP, we do it as an outpatient, and they just go home. Next day they're at work. But now they have a G tube that they have to learn what to do with this, and how to go to work with this, and how to bathe with it and do things. So it's really not very convenient. And trying to get a surgeon and endoscopist to do this in one day at one time, we know how it is. It ends up being at 6 o'clock, maybe 7 o'clock, sometime. So it's really, really hard sometimes to get everybody together and find the time in the OR. So, and then, like I said, greater morbidity. Actually, infections happen from these G tubes, bleeding, fistulas can happen. 14% risk compared to 3% risk. So this is also a significant thing. I usually have a discussion with the patient. It's really, in my mind, it's hard to tell which one. Do I take only a 60% success rate or 100%? but take a little bit more risk. I generally, just like everything else, I try to leave it for the patient. Just give them the data, give them the facts. And there are certain patients who you think this is better for them versus other patients. But at the end of the day, it's the patient choice. Next, please. One thing that I can actually tell the patient is if that rule limb that we talked about is less than 150 centimeter, we know that we're going to be successful in about 90%. How do we know that? If the patient had a Roux-en-Y bypass, say 10, 15 years ago, they did not use to make those long rule limbs. So if somebody had it, they tell you 12 years ago or so, then this is a better success. So that patient, I may not talk them out of actually laparoscopic assisted. But if somebody, and from reviewing the operative report, that the rule limb is more than 150 centimeter, your chance of success is very low. So you better talk to your surgeon and talk to your patient about that. Next, please. So this is hopefully my last couple of slides with anything other than pictures. Tips for success. So understand the post-surgical anatomy. Google whatever your patient tell you has had, or in his on his records. Review the operative reports and imaging. Discuss with the surgeon if needed. Get the right endoscope based on the anatomy. Talk to your nurses, and then also see what do you have available. Do you have tools for this scope? And then the expertise. Are your nurses? And sometimes not all of our nurses are actually expert on double balloon enteroscopy. So if we don't have the right, the nurses who know how to do this, we would use a single balloon or use a pediatric colonoscope. So the team has to know what we're doing. And then know the devices that are compatible with each scope, allow adequate time for these complex and often lengthy procedures. Again, at least we leave 2 hours for these cases, usually on our schedule. Next, please. Use water or CO2 to insufflate. Use a distal attachment cap. Fluoroscopy is very, very helpful. And then if you end up into that fork, if you guys remember, and you're done with this procedure, tattoo it. You would really appreciate that next time you go into that and know that, okay, that's it. That's the sign I was talking about earlier, that you'd actually see a tattoo from either you or somebody else who's been there and actually tattooed that limb. It really does save a lot of time. So, and if somebody else does it, they would really like to see that. Next, please. So, as an endoscopy unit, and I know that a lot of the nurse managers here as well, is it really worthwhile to be doing all this, or should we just send it to the university and get it over with? It's a really tough thing to do. We do quite a bit of this, so it's worth it for us to actually stock these devices and stuff. But for a unit that does this once a month, probably all the tools will expire before even using them. So that's something to really consider. Next, please. So these are, if anybody wants the presentation, these are devices actually that are just basically dedicated for small bowel ERCP that are long enough for these scopes. And if anybody is interested or want to know, we can look into the details and can look into the details. Next, please. And next, please. At the university, we try to keep it simple. I know a lot of what I'm discussing here are Cook products, but those are the people who make most of these, enteroscopy ERCPs. We use basically this sphincterotome called cotton cannulotome. And then we also use just a simple cannula called a glow tip cannula. So most of the time, we're successful with these. We try to keep it simple so we know what to stock. Next, please. And then our go-to wire is this long wire called Tracer Metro. Is a very long wire, 600. As you guys know, like the long wire is even 400 centimeter. This is a 600 just for these procedure. And then we use a special balloon that is long enough to go. It's also made by Cook. Next, please. And then there is a special balloon as well. These are all special tools that we use for these procedures, and we stock them only for these procedures. It's a special dilation balloon, and there is a special dilation catheter as well, so Hydra catheter. Next. And then a pushing catheter. Even if you're putting a small stent, you need a long pushing catheter for that. Your usual pushing catheter is not long enough for that. Next, please. That's it, guys. All right. Just about time. Any questions, guys? Here.
Always tattoo the limb that you want to go to
Right.
get to the pancreas.
Yes.
Do all doctors do it that way?
No. I tattooed actually just to say how crazy I am. So I tattooed in 3 spots. So I tattooed actually at the entrance, so we know where it is, in the middle, and usually just around the area of the anastomosis. So really, I mean, like this can take sometimes half hour. It can take 2 hours, sometimes even more. So if you have, and how cheap tattoo is, just tattoo it for God's sake. The patient is going to come back at some point or go somewhere, and it really takes another 2 minutes to do that. So we try, at least most of us at the university try to do that.
What's the plan for the patient who are unsuccessful?
So there are a couple of things you can do. Most of the time, if we can't do that, either surgical, like a lap assisted, if we in somebody with a bypass, or unfortunately, we hate to say it and we don't like it, is percutaneous radiology. Or interventional radiology colleagues, can, if the patient has dilated intrahepatic ducts, is they can see that under ultrasound and actually poke one of those ducts and actually pass a wire and try to retrieve any stone or dilate stricture percutaneously. The problem with this, and why we don't like to do this, so we try to be successful with what we do, is again, the patient is going to end up with a bag, with a catheter and a bag, that's going to be draining and infection and a risk of fistula and leaks and things like that. So we try to do our best before we send a patient to PTC, percutaneous transhepatic cholangiogram. But that's kind of your backup if you can't succeed. Any questions, guys? I know a lot of guys now. We'll just send it to you guys. Linda?
So these real wide gastric bypasses are getting longer because we did have one.
Right.
There's something else.
Right, and that's what I said, is talk to the surgeon, look at the operative report. Sometimes it's really not worth it to put this patient under general anesthesia for 2 hours. So if you know your chance of success is very limited, maybe it's not even worth that adventure, So, but I think more and more we're just going to see more of that, and we're going to lean more toward laparoscopic assisted ERCPs for the bypass patient, for the weight loss surgery patients. For the liver transplant patients, for somebody who had a gallbladder injury and had a reconstruction, for Billroth-2, for Whipple, I don't think those should even be talking about this. Our success rate is above 90% endoscopically, and we should be doing those. But for the bypass patient, I think we have a room to talk about that. Yes?
So I have this problem and I have to have this procedure and my doctor wants me to come and see you, but you're out of network. How am I going to pay for this? How's my insurance going to approve that I go to an out-of-network provider?
That's a good question, actually. Do you know if any doctor know anything about this? We can look into that. Yeah, I can have my case managers look into that more literally. I know. Right. Like if it's a bypass patient, I think it is acceptable. And I don't know if the guys who do ERCPs here, I think if it's a bypass patient, lap-assisted ERCP is a reasonable approach. I mean, it's not unless the patient is very, opposed to having surgery. I think it's a reasonable approach to do laparoscopic assisted ERCP. Any endoscopist who is trained in ERCP or reasonably trained in ERCP or have good expertise should be able to do laparoscopic assisted ERCP in any small hospital. If you have a surgeon who can get you a trocar in the excluded stomach and an endoscopist who is experienced with ERCP, this should be a successful venture. So I think you should be able to find a place to do that for bypass patient. Most of the other patients, and mainly I'm talking about the liver transplant patient or somebody who had an injury during cholecystectomy. Those are patients who are usually very desperate or somehow, they end up being transferred. I'm not sure about the logistics for that, but I think that most of the insurance are usually okay because it's just a very dire situation. Yes?
With the alternate anatomy, what are your post-procedural or like pancreatitis?
So just similar to the usual ERCP, if we are talking about like a bypass patient, we've seen some data, 3%, so truly not more than the usual ERCP patients. A lot of these altered anatomy patients have their bile duct and pancreatic duct attached separately. So you're saved, basically your bile ducts is there. But you still can get cholangitis, you still can get infection, can get abscesses and things like that. But it's not more than the normal rate of usually less than 5%. So it is pretty reasonably safe procedure. Excellent. Any questions, guys? Very confusing, huh? Okay. Thank you guys very much. Excellent crowd, and thanks for listening.